Slides are ready?
Yeah, slides are ready.
Okay. Okay. I think we are live. Slides are ready?
Yeah.
Ma'am, we are now live on YouTube.
Okay, so it's up to for me to start now. Okay, Simon. Okay, so good evening, everyone, and I welcome all of you to this installment of Nephrocon webinars. As you all know, we this activity is happening since last maybe 1.5 years, and every time we have eminent speakers, very eminent panelists here. So today we have Dr. Bhupesh Kumar Kaware, who is a head and senior consultant at Inlax Budhrani Hospital, Pune. He will be talking on ADPKD, its recent advances, recent understanding, and what is his own experience in his practice. I must tell you all that Dr. Bhupesh does original work in ADPKD. He tailor-mades the treatment based on the volumetric analysis, so that we are very eager to hear him. And today is a great coincidence that we are having two HL Trivedi gold medalists as panelists for us. Dr. Sree Bhushan Raju sir, who got the Trivedi gold medal in 2002, and Mythri got it in 2017. So we'll be asking many questions, and we'll be enriching our knowledge about ADPKD and how to go about it. So without wasting any time, I invite Dr. Bhupesh to start his presentation. Thank you.
Thank you, Dr. Girish, and good evening to all. I'll share my presentation now. Is the presentation shared now?
Yes, sir, it's visible.
Oh, thank you.
I think you have to put it in slideshow mode.
Yeah. So I'll be talking about autosomal dominant polycystic kidney disease with update on treatment options. So it is a multi-system disorder which affects kidneys primarily, with cysts in other organs as liver, pancreas, and arachnoid membranes. It is a autosomal dominant disease with variable expression, and we see it in 1 in every 400 to 1000 live births. And there is a progressive disease, and it mainly leads to renal failure.
I'm sorry, sir, to interrupt. The slides not moving, sir.
Is it moving now?
It's not even in the full slide mode.
You can change it to slide sharing, I think.
Is it now, sir?
I
So
guess not. I think
we are on slide number 3 right now, sir.
Okay. Is it being shared now?
you can stop sharing it. I think this is a PDF version which I'm seeing, or you can stop sharing and again reshare it. I think that should work.
Is it working now?
Not on my side. Not on my side.
Is it shared now?
Go back on one slide so that we can appreciate it.
Can it be seen now?
Now we are seeing your slides, but they are not moving. That's the.
Sir,
Okay.
I think you have to put it in slideshow mode, sir. It's not in slideshow mode.
Yeah, that's it. That's it. That's perfect.
It is in slideshow now. At least it is moving on my screen now. Is it moving?
No, earlier it was moving, but in actual when we are on live, this not moving.
Seema, if sir can send the PPT to you, will you be able to share?
Sure, sure. I think so. If you can share,
Yeah, how do I share with you?
Send
so
to
you can share,
Nephrocon.
you can share
Send
in
to
the
Nephrocon, the same email that will go to her.
Okay, email. Yeah, okay, fine. Okay, I have sent the email. Did you receive the email?
Not yet, sir. Not yet. Sir, should we just continue with the presentation till the time it is received by us?
Okay.
Yeah. I'll just do it in another 30 seconds. Yeah.
So should I start?
Yes, sir.
I
You
think
can.
I think so.
Yes, sir.
Yes,
Yes, sir.
yes.
So if we see there is a marked enlargement of polycystic kidneys as compared to the normal kidneys, and what are the clinical manifestations you see? Usual manifestations are polyuria, polydipsia due to the loss of concentrating ability, flank and abdominal pains, hematuria, hypertension. There is high chances of nephrolithiasis and proteinuria. So what is the etiology and pathogenesis? Usually it is the polycystin 1 and polycystin 2 which play a critical role in the normal function of the primary cilium that is essential to maintain the differentiated phenotype of tubular epithelium, and this disordered function is the basis for cyst formation. So what is the genetics? The PKD1 and PKD2 genes. PKD1 is located on chromosome 16p13.3 and codes for the polycystin 1 protein. It is associated with more severe phenotype and incidence is approximately 85%, while PKD2 is located on chromosome 4q21 and it encodes for polycystin 2. It has a less severe phenotype and incidence is around 15%. So whenever there is mutation in PKD1 and PKD2, there is loss of ciliary function of PC1 and PC2, which leads to reduced calcium signaling, which ultimately leads to increased CMP, that is cellular cyclic AMP, which promotes the protein kinase A activity, and it leads to increased proliferation and fluid secretion with abnormal extracellular matrix leading to cyst growth. Cysts occur only in 5% of tubules in the kidney, but the enormous growth of these cysts ultimately leads to the loss of normal surrounding tissues, and there is loss of renal function. So if we see differences between PKD1 and PKD2 disease, the clinical onset is earlier in PKD1 disease, and onset of ESRD is also earlier as compared to PKD2. These are the proteins which are located at the basolateral membrane and at cilia. PC1 is the one which is the has a site of interaction with PC2 at the C terminal site, while PC2 acts as a non-selective cation channel and it is permeable to calcium. So why only certain areas are affected? Because the genetic defect is present in all the cells, but the cysts affected are less than 10%, and there is only focal cystic dilatation. So there is a concept of loss of heterozygosity, which is due to the second het mutations, and that's why the disease develops in less than 10% of tubules. So this is a mice model where we see a threshold model of cyst formation. Here we see the wild type alleles and the null alleles and the combinations, haplotype combinations of each. The red straight line indicates the threshold below which the cyst formation will occur, while above that the cyst formation won't occur. And the dotted lines, they show the reference range where the other factors like environmental factors and the second hit comes into play. So if you see in this slide, the null and null miss2, they are below the threshold and they almost always develop polycystic disease, while the wild types, they don't develop. So this is the threshold model of cyst formation where the allele 1 and allele 2 need to have a combination which is below the threshold to develop cyst. Also, the timing of inactivation of PKD1 gene also plays a role. If you see in the A part on the left side, the mice model, there is inactivation of PKD1 at day 12, which develops into a cystic disease, while when it is induced at day 14 on the right side, there is no, they remain normal at 3 months later also. And in adults, there is inactivation which leads to late onset disease. So if you see in the panel B and C, if in these adult cases, the inactivation was induced at 6 weeks of age, but they develop cyst at 6 months. That is the C panel, which we can see there is dilatation and cyst formation. So what are the cellular pathways of cyst formation? One is translocation of sodium potassium ATPase pumps, the role of CMP and intracellular calcium, mTOR pathway, the role of cilias, tubular hyperplasia, and cell planarity changes. So the apical lateral distribution of sodium potassium ATPase is a normal transient feature in early collecting tubules, but this transtubular import of fluid into cyst happens when the apical membrane distribution persists of this sodium potassium ATPase. So if this sodium potassium ATPase pumps, they are on the basal and lateral distribution, there is no cyst formation, there is normal cellular function. But when they are distributed on apical side, there is cyst formation. So this is the histological evidence which shows that there is a cyst formation on the left side, that is A and C. These are the control slides, while the B and D, these are the cystic slides in this mice model, where you can see that the tubules on the right hand side, they are dilated, and if you say the apical part is stained in these slides. So whenever there is reduced intracellular calcium, it stimulates adenyl cyclase, inhibits calcium dependent phosphodiesterase, which leads to increased cyclic AMP, and this cyclic AMP leads to increased fluid and chloride secretion, aquaporin expression, and cell proliferation. That's why the targets of medicines have been on decreasing the CMP levels, like in vasopressin antagonists, octreotide, and also to act on decrease of CSR activation also. The mTOR pathway ultimately, if activated, leads to cell proliferation and angiogenesis, and that was the basis of using mTOR inhibitors to decrease or reduce the growth of the cysts. Now, what is the role of cilia? These cilia are located on renal tubular epithelial cells, and they sense the flow-mediated deflection of ciliary axoneme and increase influx of calcium. But whenever there is a PC1 inactivation, it causes defective sensory perception of flow, and it leads to reduced intracellular calcium, leading to increased CMP and then cell proliferation and fluid secretion. In cystic diseases, the cell planarity of these tubular epithelial cells are also lost. So if you see on the right side, there is a diagram which shows that when the cell polarity is lost, there is increase in the width, and that leads to the dilatation of the tubules, leading to cystic disease. So how is the diagnosis? Diagnosis is usually by a family history and by imaging tests, in which ultrasound is used very commonly, while CT and MRI are more sensitive. So when will you suspect ADPKD? With clinical features and those who have a family history, and in incidentally in patients who underwent abdominal imaging for a different indication. How do you establish the diagnosis? One is by getting a detailed family history and then corroborating it with imaging. Genetic tests are usually reserved for atypical cases or to rule out ADPKD in a young potential kidney donor. So in an asymptomatic patient with normal kidney function and who has a family history, ultrasound is usually sufficient to diagnose or rule out the disease. MRI or CT will be required if the ultrasound is equivocal or if we have to detect incidentally detected complications like complex cysts or kidney mass. However, whenever you diagnose ADPKD, a baseline CT or MRI should be done to calculate the height adjusted total kidney volume, and that helps in risk evaluation and the need for disease modifying treatment which will be given afterwards. Whenever you take family history, the number of points which should be taken are: one, what is the number and relationship of family members affected? What was the age at diagnosis? What was the age of developing the end stage renal disease? And any other known genetic mutations in the family. Obviously, after taking a family history, we'll corroborate it with imaging. So this is the ultrasound diagnostic criteria of PKD1 which we have studied. In age less than 30 years, you require total of 2 cysts in one or both kidneys. 30 to 60, total of 4 or more cysts. And in more than 60 years of age, 4 or more cysts in each kidney. And the sensitivity ranges from 84 to 100% with specificity along same lines. So this has been developed only in patients who have positive family history and those who have PKD1 disease. And when this study was done, the ultrasound machines were capable of detecting cysts that were 1 centimeter or more. But nowadays we can detect cysts of 5 millimeter or more with certainty, but ultrasound remains a center and operator dependent modality. So that's why we may need to take a choice between a CT or MRI, and it depends on the patient's kidney function given the risk of exposure of contrast with CT. Though plain CT is more than enough to get a diagnosis. In patients who have GFRs more than 60 mils, we can go with contrast study to see how is the cyst burden assessment and to identify between cystic and non-cystic tissue and identification of any stones in the collecting system. The EGFR less than 60 mils will usually prefer a MRI. So where would the genetic testing done in the management of CPD, ADPKD? So it is clinically indicated when there is no apparent family history or the kidney imaging findings are equivocal. ADPKD exclusion in young patient at risk subjects while having a living related kidney donation or obtaining life or disability insurance. Also, whenever there is a atypical clinical presentation, we want the genetic test to be done. So what is the atypical clinical presentation? One is early and severe disease, a discrepancy in imaging findings and the kidney function, asymmetric, unilateral, segmental or lopsided cystic kidneys, and syndromic forms of polycystic kidney disease. So here we will prefer to have genetic test and to confirm whether it is a ADPKD or not. So what are the usual complications which we see in ADPKD? We can divide it into cystic and non-cystic or non-renal complications. In cystic complication, renal cysts and non-renal cysts. the complication due to renal cyst can be hypertension, pain which is present almost in more than 90% of the patients, bleeding, urinary tract infections, infected cyst, renal stones, progressive enlargement of the kidneys and liver leading to abdominal discomforts, and sometimes anorexia leading to malnutrition, and then decline in renal function. So liver enlargement, pancreatic cysts are uncommon, but typically they do not affect the function, while liver function can be affected with large cysts, and arachnoid membrane cysts usually are asymptomatic but will need a monitoring. The non-cystic complication which mostly we fear is the intracranial aneurysm, which is present in up to 8% of patients, and we usually diagnose them when any family history is there. Then we go for imaging to find out whether there is any intracranial aneurysm. Then cardiac wall abnormalities mainly of mitral valve, aortic dilatations or aneurysm, and thromboembolic events with hernia and diverticulosis, the other main complications. So whenever there is a suspected acute cyst complication and patient presents with fever and abdominal pain, it's always better to get abdominal CT. And if there is a certainty of a cyst infection, we go and treat for that. If there is uncertainty, then we will look at the CRP levels, whether CRP levels are high or not. Also, what is the intracystic density, whether it is more than 50 Hounsfield units. If that is so, then we will treat it as cyst hemorrhage. So CRP negative and intracystic density more than 50 Hounsfield unit will treat it as cyst hemorrhage. While if CRP is high with blood culture positive, urine culture positive or leukocyturia, we will make a diagnosis of probable cyst infection. PET-CT is a good imaging modality to tell us whether this is a infected cyst or not. And if we can diagnose it, we treat it according to the lines of cyst infection. So fluoroquinolones in combination of cephalosporins are the drug of choice in treatment of cyst infections. Usually a higher dosage should be considered, and once the causative bacteria is identified, we should go for the specific treatment. Usually antibiotic therapy should be initiated as early as possible, and treatment should be tailored according to the cultures available later. So no specific medication is available for treatment of ADPKD, but some approaches for targeting the slowing of renal disease progression have been undertaken. One is targeting cell proliferation with sirolimus and everolimus. Other is by reducing CMP levels with somatostatin analogs and then tolvaptan. The other approaches which have been attempted but have not succeeded and are not as of now suggested, these are the PPR agonists, methylprednisolone, amiloride, caffeine restriction, EDGF inhibitors, but they have all fallen out of favor and are not used. So what is the newer treatment paradigm? One is to treat the cystogenesis and decrease the inflammation ischemia by acting or decreasing the AVP levels. So that's why we are treating with tolvaptan, that is a specific V2 receptor blocker, and leading to decrease of AVP, which helps in slowing down of the cystogenesis. So whenever we confirm a ADPKD diagnosis, if it is a typical ADPKD, that is bilateral and diffuse cyst distribution, we measure the total kidney volume by CT or MRI. We then classify by Mayo classification. If it is a 1A or 1B, we reassure and we confirm the rate of progression in next 2 to 3 years. If it is class 1C, 1D or 1E, we treat it as rapidly progressive ADPKD, and if eGFRs are more than 25 mils per minute and age is between 18 to 55, we start on Tolvaptan therapy. The other general management of ADPKD in all cases should be done. In atypical ADPKD also, we should go for all the general management of ADPKD, like blood pressure control with a goal of less than equal to 110/75, with ACE and ARBs being the drugs of choice. Moderate sodium restriction up to 3 grams per day, increase hydration up to 3 liters of fluid intake to decrease the urine osmolality to less than or equal to 280, and then the moderate caloric restriction, maintain normal BMI, and then maintain a serum bicarbonate of more than 22 milliequivalents per liter. So this is the Mayo classification, which classifies the patients into class 1 and class 2 based on CT or MRI finding. So in class 1, these are the typical ADPKD cases. There we again diagnose them into or classify them into A, B, C, D, E, and this is around 95% of cases. So how do you classify them? That depends on the total kidney volume, which I'll come to later. And in the atypical ADPKD, it is classified as class 2, where there is a focal disease and parenchymal atrophies. So what is the significance of classifying them into these all classes is that the rate of progression can be assessed or decrease of GFR can be assessed. While in 1A it is less than 1.5%, while in 1B it is around 1.3 to 3%, in 1C it is 3 to 4.5%, and in 1D it is 4.5 to 6%, while in 1E there is more than 6% per year chance of loss of GFR. So the advantage is to predict individual EGFR at any point in future in using a single TKV measurement. It requires a demographic data like age, height, and TKV. TKV is total kidney volume, which can be calculated using a TKV calculator, which is available online, and by using a single representative coronal and sagittal lengths and width and depth measurements of both the kidneys. And the modality can be CT or MRI and without contrast. The calculator is based on the formula for an ellipsoid. So here in this stage, first step is to have the maximal sagittal length. Then step 2 is to have maximal coronal length. In step 3, maximal width and depth. And you plug in all these measurements in this online formula. You calculate the TKV, following which you add on the height, age, and you get the Mayo classification. Based on this classification, then you estimate the future EGFR or time to ESKD. And here on the right hand lower corner, you can see that what is the current EGFR and what is the future EGFR predicted. You can see at the same time. So this is the graph which shows the diagram A shows us the relation between the patient age and HTKV with the class. As the class increases, the TKV increases. So class E has the highest TKV in a patient. The graph C tells us how the EGFR will progress from the day of calculation of TKV. So if we see in class E, which is the red and which is the lowermost line, you can see the progression is vertical and patient will progress to end stage renal disease by 10 to 11 years from the day of calculation. So the categories C, D, E have a high progression, while A and B have a less progression. So other criteria which have been taken into account, and this is published by the European Renal Association, and this is the algorithm to identify the rapidly progressive ADPKD diseases. In this, many other criteria have also been given, including Mayo classification, and the other class which are taken into consideration are: one is kidney length by ultrasound, which is more than 16.5 centimeter. in a patient age less than 45 years, or a TKV increase of more than 5% per year by repeated measurements, preferably 3 or more, each at least 6 months apart. But here the problem is that you will need to go on doing the test 3 or more times, and is operator dependent also. If EGFR decline is more than 5 mils per 1.73 meters square in a year, or more than 2.5 per year for over 5 years, it will be considered as a rapidly progressive disease. So once you identify the rapidly progressive disease, then you think of adding them onto the treatment of Tolvaptan. The last score is the pro-PKD score, and if it is more than 6 years, more than 6, then we can consider it to be a rapidly progressive disease. So what are the criteria in pro-PKD scoring system? One is male, second is hypertension before age 35, first urological event before age of 35, PKD2 mutation, non-truncating PKD1 or a truncating PKD1 mutation, and then the points are given, and based on that, if it is more than 6, it is considered to be a high risk rapidly progressive ADPKD. So these are all the biomarkers with which we can assess the risk of progression, and each and every parameter has got its own pros and cons. But if you see here, Mayo imaging classification, though can be easily done with good reliability, it is cost and operator dependent and needs precise measurements. So every parameter has got its own plus and minuses, but these are the parameters on which we can assess the risk of progression in ADPKD. So the TEMPO trial and the REPRISE trial, they showed us that Tolvaptan can slow the increase in total kidney volume and the decline in kidney function, which has led to Tolvaptan being the cornerstone for treating these rapidly progressive diseases. And the basis is that you inhibit the V2 receptor, and which leads to downstream decrease in signaling, and leading to inhibition of sodium potassium ATPase pump at the last step, leading to decrease in generation and persistence of fluid filled cyst. So that is the basis of using V2 receptor antagonist, that is Tolvaptan. So what is the algorithm for starting the Tolvaptan? One is, whenever you have a rapidly progressive disease, you exclude all the contraindications. So what are the usual contraindications? Are hypernatremia, hyponatremia, patient having liver dysfunction, or patient having urinary tract obstructions or inability to control the thirst. So these are the usual contraindications. If these are not there, we can start them on Tolvaptan. The recommended starting dose is 45 milligrams in the morning and 15 milligrams in the night, and you titrate it every 1 to 2 weeks. And the maximum dose which is to be given is 90 milligrams in the morning and 30 milligrams in the night, or whichever can be tolerated. And usually it needs to be monitored with urine osmolarity, and target would be to have urine osmolarity less than 280. So after once you have started and have maximized the dose, you monitor the treatment efficacy by looking at the EGFR, the rate of decline. A GFR decline more than 30%, you should go down on the dose or stop the dose. And then you look at the TKV rate, what is the growth every 3 to 5 years, and what is the impact scale on ADPKD quality of life. So this is how you start and monitor Tolvaptan. And on monitoring side, you always check for LFTs. First you check weekly, and then you can go on checking monthly, and then 3 monthly. The LFT derangement is the one thing which we want to check regularly, and if it is more than 3 times the upper limit of normal, then you need to modify that protocol. I will show you after this slide. If sodium is more than 143, then you reduce or hydrate the patient. If it is less than 135, you reduce the hydration. And if eGFR drops to more than 20 to 30%, you reduce the dose or hold the tolvaptan. So what happens when there is liver dysfunction? This is one algorithm how to manage liver dysfunction when patient is on tolvaptan therapy. So if it is more than 3 times normal, you stop the treatment and you don't restart it again. But if it is more than 2 times but less than 3 times, you hold the tolvaptan, you repeat it again in 48 to 72 hours, see whether it has decreased or stabilized. If it has stabilized, you reinitiate the treatment. But if it again increases or is increasing more than 3 times, then you permanently discontinue and look for any other explanations of liver injury also. So if the bottom line is, if the rise in levels is more than 3 times the upper limit of normal, tolvaptan should not be again restarted. So what are the benefits and harms of tolvaptan? One, it will slow the kidney growth, slows eGFR decline, and may delay the need for renal replacement, will improve blood pressure. Harms are polyuria, nocturia, thirst, fatigue, hyperuricemia, transaminase elevations, and financial burden. As of now, we get tolvaptan at one tablet at around 120 to 160 rupees. And if we are seeing the dose, the highest possible dose, the financial burden is huge. And whatever the programs which are being given for tolvaptan reduce the cost by almost 30 to 40%, but the rest people have to still pay. So the cost is the main factor in giving this treatment. So the NICE guidelines also suggest that you should start tolvaptan only if the financial access is there or the scheme is there to give the treatment. So what about the other treatment modalities which have shown no benefit? One is mTOR inhibitors. They have not shown any benefit in kidney function, but though they showed stabilization of cyst growth at 6 months, and sirolimus was used very commonly before, but nowadays we don't use mTOR inhibitors. And somatostatin analogs, they have not shown to slow the progression of kidney function decline, and so they are also out of favor as of now. The other one part was the metabolic reprogramming and the use of metformin to decrease the rate of glycolysis and to have a decrease in mitochondrial oxidative phosphorylation, but that also has fallen out of favor. So these are the trials which have made possible use of tolvaptan. This is the TEMPO trial, and it was mainly done in 18 to 15 years of age, inclusion criteria with GFRs of more than 60, and TKV volume was more than 750. And what was seen, it was a drug placebo trial, and what was seen was that the decline in function of kidney function was less with tolvaptan, though there were increased liver enzyme adverse effect noted with tolvaptan. The other is the reprise trial, where there is suppression of vasopressin levels with increased fluid intake, and it was a pilot study. Results showed that chronic water load increase urine volume, and that led to decrease in cyst growth, but it is less practical feasibility, and we need to monitor the sodium levels. This is the trial on somatostatin, where a large RCT of 34 patients, and results after 1 year showed that the mean kidney volume was stable in somatostatin arm, and GFR reduced to some degree in the both placebo and somatostatin arms. This is the trial for mTOR inhibitors, where there was Everolimus was the drug studied with placebo, and the decrease in GFR was almost similar in both the arms, and increase in TKV was also similar in both the arms. That is 230 ml in everolimus group and 310 in placebo group. The other trial also showed no change in TKV or GFR after 18 months. So this is one slide which is showing all the trials together, in which I had spoken about tempo and reprise trial. While the halt PKD trial was a trial for use of ACE inhibitors and or ARBs, and it showed late results showed that there is no difference in TKV or eGFR, but in early trial it showed that blood pressure target of 110 in patients who have rapid progression will help in decrease in the TKV size and preservation of GFR. The rest all trials have not shown any benefit, but the tyrosine kinase inhibitors, that is bosutinib trial, is being watched as of now. Now, what all about the specific managements of end-stage kidney disease in ADPKD? I'll talk brief on this. Kidney transplantation, the survival of these patients is either similar or better as compared with other causes of ESKD. Some unique complications after transplantation can be post-transplant erythrocytosis, symptomatic aneurysms, diverticulitis, and urinary tract infections. Hemodialysis survival of patients with ADPKD is better as compared to other causes, those who are on hemodialysis, and the cause is basically due to lower incidence of coronary artery disease. Clinical problems more frequently observed in these patients are gross hematuria and kidney pain and infection. Peritoneal dialysis is possible, and survival rates have been shown to be better than other causes of ESKD, though peritonitis risk is more as compared to other diseases, and usually is secondary to cyst infection or complications of diverticular disease. Now, when the nephrectomy would be considered in ADPKD, one is debilitating abdominal discomfort, which is not going away, marked anorexia leading to signs of malnutrition, a suspected RCC, uncontrolled kidney hemorrhage, ventral hernia due to massive rhinomegaly, a kidney infection which is not getting controlled or with a gas forming organism, and staghorn calculus in a non-functioning kidney causing recurrent UTI. Also, nephrectomy can be considered during transplantation if the size is the issue and it is occupying the right renal fossa, right lumbar region where we want to keep the kidney. So there we can do a selective nephrectomy. That is another indication. So ADPKD requires a multidisciplinary and patient-centered case and coordinated efforts of many divisions of medical care. So this is one slide where we can summarize where we want to treat, where we don't want to treat, and where shared decision making can be done. If you see on the left hand side, the case number 1, 2, 3, which are the rapid progressors. So in that number 1, if you see TKV volume is very high, the patient is in class 1E, and though the pro PKD score is less, we will like to treat this patient. The second, also TKV value is high, it is class 1D, we would like to treat it. In case number 3, though the pro PKD score is less, TKV volume is also not high, but patient is in class C and eGFR is high, we would like to treat this patient. And the rest slow progressors and those who have decline in GFR not related to ADPKD, we don't want to treat. And shared decision making in a patient whose age is more than 55 years, because the trials had not included patients who have age more than 55 years. So that's why we want to discuss with the patient the risk benefit and then decide whether to treat them. So these are the references, and thank you for patient hearing.
Thank you, Dr. Bhupesh. That was a very, very elaborate account of ADPKD. Actually, it's a very huge topic, but you could cover it nicely. So I think this is time for our panel discussion, and we have two panelists, Dr. Mythri and Dr. Sree Bhushan Raju sir. So Simaji, can you put up the panel discussion slides?
Sure, sir.
Yeah, next slide. Next slide, please. Yeah, so first question is to Dr. Mythri. Uh, See, we have seen all this account of ADPKD, but there are few knowledge gaps or few unanswered questions here. What are the key clinical and imaging features that help you differentiate ADPKD from ACKD in dialysis patients? And the second will be, is significantly enlarged kidneys size is a necessary criteria to diagnose ADPKD, particularly in early or atypical disease. When I say enlarged kidney size, I want to highlight the fact that all the studies and the literature and measurements are from Western literature, and we know that Western kidney size is always larger than the Indian kidney size. So this is a, I think, a gray zone where we can address whether those measurements hold valid for the Indian population. Dr. Maitri.
Thank you, Dr. Girish. Thank you, Dr. Bhupesh, sir, for such a wonderful talk. And it was really comprehensive. And we all learned a lot as well. Thank you so much for that. And moving on to the questions. Thank you, Dr. Girish, sir, for the questions. As you rightly pointed out, it is very important to differentiate ADPKD from acquired cystic kidney disease, especially in patients who are on dialysis and with no clear family history. And of course, there are some clinical and imaging features which will help us in distinguishing these two. Dr. Bhupesh sir clearly mentioned, ADPKD is an autosomal dominant disease with a positive family history, which is quite common. But we don't see that kind of family history in acquired cystic kidney disease. Usually it is sporadic and there is no genetic transmission. And the cysts develop probably in childhood or adolescence, and often they become symptomatic by 30 to 40 years of age in ADPKD. While in ACKD, it is only after the patient moves on to dialysis, and he's on dialysis for a while, and that is only when they start developing cysts. And ADPKD is the main cause for kidney failure, whereas in ACKD, it is because of kidney failure and because the patient is on dialysis, that is exactly why they start developing cysts in the kidney. ADPKD, again, we have extrarenal manifestations like liver cysts, intracranial aneurysms, mitral valve prolapse, which is not seen in ACKD. The kidneys are massively enlarged in ADPKD, while in ACKD, they can be small or even normal sized. Our patients with ADPKD usually present to us with symptoms like infection, pain, hematuria, or cyst rupture. But these ACKD patients, they hardly have any symptoms. They are usually silent or asymptomatic, just that they are at increased risk for renal cell carcinoma. And on imaging, clearly ADPKD, we see the cyst distribution is bilateral, symmetric, diffuse, and the cysts are numerous in number, often more than 10 per kidney by the patient, by adulthood. By the time the patient reaches 30 or 40 years of age, we see that there are already more than 10 cysts in each kidney. Whereas in ACKD, the cyst is often scattered and asymmetrical and usually very less in number, maybe less than 10 per kidney. So we consider acquired cystic kidney disease if it appears late and there are very few cysts, kidneys are small, and the patient has a very long dialysis history. So this is the bottom line. And your next question was about enlarged kidney size, right? Enlarged kidney size, whether that is required for diagnosing ADPKD, that is actually a great question. Because we usually, significant enlarged kidney size are not always necessary to diagnose ADPKD, especially in early stages or in atypical cases, they may not come to us with enlarged kidney size. Even the KDIGO 2025 recent guidelines emphasizes on a context-specific approach that is combining imaging, family history, and also sometimes genetic testing to interpret such cases. So when does the patient come to us without enlarged kidney? It is usually in three conditions. One is early stage ADPKD, that is young adults who may have very few cysts and normal sized kidneys, especially if the mutation is in PKD2 or if it is a non-truncating PKD1 variant. And atypical ADPKD, like Sir clearly mentioned, some showing asymmetric or just segmental cyst distribution without any gross enlargement. And minor gene mutations like DNA JB11 or glucosidase 2 alpha subunit. So these gene mutations may not the kidneys may not be very large. They may be normal or even small kidneys with some fibrous or few cysts here and there. So coming to borderline kidneys with few cysts and strong family history, as again Dr. Bhupesh sir clearly pointed out, KDIGO also suggests age-specific ultrasound criteria. We have age and the number of cysts that are required for it to be diagnostic. So if that cyst count is below threshold, then ADPKD is definitely unlikely, but we cannot completely rule it out. So that is when we have to consider MRI. If MRI is more sensitive, then KDIGA allows the diagnosis if there are more than 10 cysts present totally, putting both the kidneys together in between ages of 16 to 40. And again, if you feel that the MRI results are equivocal, we move in for genetic testing, which is almost like gold standard. So it is usually recommended whenever there is discordance between imaging, GFR, or someone like this who is young in age with unclear phenotype, living related donor considerations, and someone coming with atypical extrarenal features. So few cysts, strong family history, and young age. Likely the patient has got early ADPKD. We would just suggest follow-up of the patient. And if the patient is insisting you to get genetic testing done because he's very anxious, he has a strong family history, and then at that point of time, maybe we would go ahead with genetic testing. Otherwise, we would just simply follow up with imaging. Hope
That's
that
what
answers.
that's wonderful. I think that's wonderful. So, the borderline category of Mayo is still borderline for us. Like the borderline is not aggressive category for Indians because we are still considering the kidney size matching with the Western population. So that's wonderful. Can I have the next slide? So this I just wanted to put everything in a nutshell that whole PKD program which Dr. Bhupesh has also told us that what is the experience of the panel using the ACE inhibitors and ARBs, because this particular program has showed no difference in improvement in EGFR and occurrence of CKD and the increased incidence of hyperkalemia. But those early categories like 1A or 1B. So what is your take on using these lisinoprils or telmisartans or any other conditions? Dr. Mythri?
So we generally put them on ACE inhibitors or ARBs, of course, with monitoring of hyperkalemia. So we strongly believe that ACE inhibitors does help in reducing the progression of ADPKD and also, the fall in GFR as well. So yes, we definitely use ACE inhibitors with the monitoring for hyperkalemia.
Do you use a combination of ACE inhibitors and ARBs, or you use a monotherapy?
No, just we use monotherapy.
So my the same question I will take it to Dr. Sree Raju sir. Sir, good evening.
Yeah, good evening. Good evening.
So what is your take on using ACE inhibitors and ARBs in the early stages where the Mayo says we need to give them assurance and wait and watch and follow them up. So what will be your approach for that category, that gray zone?
In fact, we have been treating these patients early with the ACE inhibitors or the ARB right from the beginning, before the advent of this particular drugs, secondary to the tempo trial, repress trial, and all other things with the Tolvaptan and so many other drugs. In fact, when we were students, almost there were 15 to 20 drugs and the molecules were under evaluation for the management of these patients with ADPKD. And right from the childhood onwards, interestingly, there used to be a very wonderful cartoon in Kidney International those days, probably in 99 or 2000, And it showed clearly that what are all the stages where we can intervene and put some treatment so that the rate of progression and ultimately the reach of to end-stage renal disease would come down. But actually, interesting to note that none of these molecules, whatever we have been discussing now and whatever Dr. Bhupesh and other people have actually depicted in their slides, none of them were actually discussed nowadays, and they're entirely different. That included even the steroids and some of the vitamin E and those kind of drugs.
Yes.
Very interesting. But with the advent of this drug, the Tolvaptan, where we need to put some control over the mechanism of vasopressin inhibition and cyclic AMP activation, all these things, the new drugs have come up and they showed some interesting, important reports in some of the patients which are selected and very highly selective group of people who got benefited out of that. But the amount of the benefit is just 1 ml per minute per year, approximately, and probably not more than that actually. And whereas on the contrary, by nature, the ADPKD itself is actually very slow progressive in most of the people. That's why,
Yes.
though we have families of ADPKD people where we can see 5 to 7 people, of which only one fellow will be having a rapid progression, and
Yes,
whatever the way you
yes.
do it, you will not be able to control also.
Controls.
The most important thing is that, like most of the nephrologists, we are biased towards ACE inhibitors and ARBs. The moment you find a little bit of elevation of the blood pressure in a family, in a patient with a family history of kidney disease, people who are young and having a hypertension, however little it may be, say it can be 140/90 or 130/90. There's nothing wrong in starting a little bit of ACE inhibitor and ARB
Yes.
in them, and
Yes.
it's in a tolerable doses, not in a very significant and high doses. So nothing wrong in that, and you continue to give the same ARB or ACE inhibitor for a very, very long time. I'm very skeptical about the question which you asked me about the Tolvaptan truly slowly progression or not. To be very frank, I don't give a lot of Tolvaptan to many people. It can be given across all the even in the end-stage renal disease nearer to that also people have given, and some studies are also showed that people who had a progression and low GFR also people tried in some of them. But the risk profile, but I'm sure that none in India, no nephrologist in India is actually adding, truly giving the dose which is being given in the tempo trials.
Yes.
So none
I
of
was
us are using that. In fact, I with a lot of difficulty and hesitation, I started say 50 milligrams, 30 milligrams, and 50 milligrams, and only 30, 15, 15, 30, something like that on and off. And in case if he complains a little bit also, then I'll decrease the dose. So that kind of a thing was difficult. Whatever the drug advocated by the clinical research protocols, which we could never use it in our clinical practice.
So is it the cost that is the barrier?
The cost
Or
is bigger, and some of the risk factors like even hepatotoxicity, which also is significant in these people. And with a little bit of dose also, we could see in some of them. So that is another reason why we are very hesitant to use that. And the amount of benefit which probably we can get or expect out of this particular protocol is actually minimal. That's why most of the people are not so keen in. And whenever I interacted with many people, they say that the full dose will not be given, and they're not thinking in terms of using it. Even if they start, it will be not more than a few months or probably up to a year or so, not more than that.
but the tempo 3-4 says that the results and outcomes of these patients are little delayed, and if we are using it for 3 to 6 months, probably we are not reaching up to the outcomes. So that is a wonderful point. These are the words of wisdom, Mythri, because sir must have seen more than 1,000 patients of ADPKD. So next slide, please. So this is again we are coming back to from medicine to surgical aspects. So what is your take on the surgical deroofing in patients with large cysts? And what have been your experience? Have you ever advised your urologist or surgeon to go for a deroofing or a nephrectomy or do something surgically? Do you prefer to put these patients under knife if you have to?
So, as you rightly mentioned, surgical deroofing is considered a valid option for patients with ADPKD who have exceptionally large kidney or liver cysts that are causing significant compressive symptoms like dyspnea or abdominal distension, pain, or early satiety. Usually, it is laparoscopic cyst fenestration that is particularly recommended for large and symptomatic. And if you can identify that dominant cyst, which is easily you can approach it easily. Either it should be anteriorly located or caudally located in the liver for it to be easily approached, or it should be more superficial. Even the KDIGO recommends the same, but studies have shown that there is high rates of recurrence, and complication rates are also high, close to 30%, including risk of mortality of 2%. So what we prefer is we go for less invasive procedures like just aspiration sclerotherapy, only if the cyst is causing trouble to the patient, and if we are able to identify one particular cyst which is superficial, and we are sure that it is the dominant cyst which is causing the symptom to the patient, and the cyst size is more than 5 centimeter. This is usually rare. Usually they have multiple cysts which is troubling them, or it may, and the trouble might not be too much for them to go under the knife. So I've probably referred 2 or 3 patients till date to the interventional radiologist for aspiration, but not anyone for laparoscopic cyst fenestration.
Right.
But yes, we have had patients who have undergone nephrectomy for recurrent hematuria, recurrent infections, and also symptoms. But these are the ones who have already lost their kidney functions and they're on dialysis. They're either waiting for transplant, or they're coming in with recurrent symptoms like hematuria or cyst infection, or pain abdomen repeatedly. So yes, nephrectomy, yes. Aspiration, yes, but surgical de-roofing, no. And cyst aspiration, we have seen, we have seen immediate symptom relief. The patient is very happy. The cyst reduction is also happening very fast, and it is minimally invasive as well. But of course, yes, there are chances of recurrence in cyst aspiration, because we are just finished. I mean, they're just making holes on the cyst and aspirating the fluid out. It can reaccumulate again anytime, but short-term benefit is definitely there for the patient. At least the patient is happy for some period of time. Yeah.
That's perfect. Thank you. So next slide, please, Simaji. So these are two wonderful questions for you, sir. We can't stop ourselves from asking you more questions today. So what is the most comprehensive gene panel available in India that you would recommend? This is the first question. And second, would you recommend genetic testing for adolescents if a parent has an ADPKD? Like age group, very less age group, 14 years or 13 years or 10 years, because just hypothetically 50-year-old woman diagnosed and her daughter is an adolescent. So what would be your approach and counsel this family regarding diagnosis, prognosis, and surveillance, because this is an autosomal dominant? So that's why how will you deal with the younger age group people in that family?
Yeah, actually, recently we just started looking at this genetic variability in some of the patients who are presenting to us with atypical manifestations, both clinically, radiologically, as well as the clinical course-wise. So naturally, we'll be thinking in terms of how they got into, even within the same family, also people have got a different varied manifestation, which are actually putting us into trouble. In fact, I need to tell you that to my surprise, I got so many varieties of reports actually. I've been treating one doctor, is a medical doctor who has been to US, and before leaving to US, he came to me around 20 years back, and he was an ADPKD, and he have a good number of his family members had ADPKD, and there's no doubt about the ADPKD. Then he went to US, he got married there only, and he's been living there, and his mother became my patient later, and she has been coming to me regularly. Then around 7 or 8 years back, he underwent a genetic profile there, and it was actually PKD1. Interestingly, when he came to me, he didn't even tell me that whatever the report he got it done, and he forgot actually that he got a test done on genetics, because 7 or 8 years back. Then he came to me, then I got a genetic test done with us, a whole exome sequencing, and especially telling them about to do the ADPKD. I wrote also that is the ADPKD family. We have so many members of his family having ADPKD, and some of them died and some had renal failure. Some are still in my follow-up. To my surprise, he got a report of juvenile nephronophthisis actually.
Okay.
And interestingly, his mother also report came as a nephronophthisis. I don't know whether it is actually anything to do with this particular thing or not. Then I told him, you please check some. Then I called him, and he's in US, and I called him and just find out whether you got any other report. Then some of the reports which he sent, I found that is ADPKD1. Now, how come the genetic panel differs from one country to the other country, and the same blood cannot really give another one? But interestingly, some of our patients also had varieties. But the genetic panel, not only just PKD1, PKD2, and then this is probably NGS, whatever the thing which we have been asking, the whole sequence and other things. We should give varieties of things that could include the GNAB, GANAB, and DNA JB1, JB11, and HNF and PKHD also. PKHD also we are getting one on and off. We are seeing those reports also. Interestingly. So, but this is actually surprising. My surprise did not stop here. And another 1 or 2 patients who are my own follow-up since a long time, when I got a genetic analysis, they also came as a nephronophthisis. No, I'm curious now and trying to understand and trying to explore whether anything related to this particular gene, which probably, if they survive the disease, probably as they grow up, they become PKD or not. So very interesting. But many of them are variants of unknown significance. And this kind of reports, when we get, automatically we'll be worried whether to believe these reports or not. But I'm surprised how come they pay a report from US 7-8 years back would pick up PKD1, and our report actually could not pick it up and made it as a juvenile nephronophthisis. So these are the things. But as you wrote, one of the questions that the comprehensive gene panel, I think, includes all whatever I narrated. All of them are there in that.
Yes.
And atypical presentations, as I said, unilaterally PKD and early manifestations and severe manifestations, and some of the clinical manifestations which are not correlating. And these are the indications where we can actually ask them for the genetic panel. And somebody is trying to donate a kidney also, there also we can ask them to go for a genetic analysis. And adolescents, 14 years, no. Actually, usually I tell them to start checking from 15 to 18 years onwards.
Okay. Okay.
Total, the family is very keen and understanding. I can tell them even from the birth onwards, get an ultrasound abdomen. But many people will not be keen. And we know that ADPKD typically manifests after a certain age. The interesting thing is I had a grandfather who has been my follow-up, father my follow-up. The grandson came to me with renal failure followed due to ADPKD. So in that way, at the age of 27, 28. So it is very interesting to know that kind of a thing. Maybe some genetic variations must be there, but better not to screen for the genetic testing. Leave about in India, but in other countries, the genetically, if you find an adolescent with a genetic analysis showing some kind of kidney disease and all, they might not be get a good insurance also later in their lifetime. So better not to trouble them, and better not to do the emotional turmoil. It can lead to emotional turmoil of the family members.
Yes.
18
I
years
agree.
and above only we can do that, which many people, they ask me in the WOPD, sir, can I get some tests? Then I tell them, get an ultrasound, but don't worry about any of the things. But genetic tests, better not to do unless you feel that there's a controversy and conflict between ARPKD versus ADPKD. ARPKD came to me and when the patient is actually around 17 to 18. It was surprising to me. So these kind of a funny reports we'll be getting in genetics. But better not to trouble the adolescent suspected ADPKD family members. If you have a disorder which is clearly shown, it is okay. And another 50-year-old woman diagnosed at the age of 42, father detected 65. The daughter incidentally have a few cysts on the ultrasound. What would you approach and counsel the family? Yes. And 50, she's already 50 and father had a 65. And a few cysts of her daughter probably. And the way it is progressing, I don't think we should really trouble them. You can counsel them and that should not be a problem at all. Like the grandfather detected at the age of 65, mother still is okay at the age of beyond 50. Then the daughter with a younger age, we should not really trouble them. Counsel them that this is a disease and the surveillance is very, very important, and more rather than the genetic screening and genetic counseling. It is basically the surveillance, very important. And the prognosis, according to me, I feel I will give a good prognosis only to them because such a good family history where the things were actually going smoothly beyond 65 years of age group.
So just taking the discussion a little ahead in the genetic arena, we know which gene is involved. We know which mutations are involved. We know whether it is truncated, not truncated, complete penetrance, incomplete penetrance. So why are we still not talking about gene therapy in ADPKD? Dr. Raju sir.
Yeah, gene therapy was actually there since a long time, actually. When we were students 25 years back also, it was discussed about, actually. And one of the things which I was telling you in the KI, the article, that also spoke about the gene therapy. Interestingly, it's probably may not be possible. The ADPKD itself, the detection itself is so difficult as far as the genetic studies are concerned. And giving a good therapy for the genetic therapy may not be possible now in next few decades. So let us hope for the best and give them. But now the reports are there and some of the people are talking about genetic gene therapy in ADPKD and other conditions. But it will not be possible in next few decades, according to me.
Actually, the
complexity involved in the ADPKD formation itself is actually difficult and complex. So it's very difficult to chase that.
Okay. So your take, Dr. Mythri, on gene therapy, would you foresee, or do you feel it's just a science fiction?
No, with CRISPR technology in place, and now we are seeing transplantation, the pig kidney and all that stuff, I'm a little optimistic. I don't know, Bhushan sir knows more than me.
Not because of that. But it is basically the gene therapy when to introduce ADPKD. Using the technologies, giving the therapy afterwards is actually okay. But
Yeah.
these are the congenital genetic disorders which manifest very, very late, actually. That too when you are in 30s, 40s, and 50s.
Yes.
So
Yes.
whether we can go back and then a ethical dilemma also will come: who should be treated and who should not
Yes.
be? And
Yes.
do you treat all and each and everyone? Is it possible for us to treat and each and everyone? And especially when the family history is not so bad and
Not
not
so bad.
everybody
Yes.
gets into
Yes.
renal failure, then if at all not
Yes.
everybody is getting a renal failure, then how will you choose the fellow to whom to treat? So these are the ethical issues also should be considered. The things will
Yes.
come, but introducing the modified gene into a gene therapy for a ADPKD like condition, maybe okay, it might probably maybe they may not be the first one to get into gene therapy, but maybe the third, fourth, or fifth disease which can be
Yes.
treated with a gene therapy in nephrology practice.
Right. Thank you. Thank you so much, sir. Thank you for all this wisdom. Next slide, please. Mythri, these are the last slide for today's discussion. So how useful is the Mayo classification in guiding prognosis for your patients in your practice? And can ADPKD increase the risk of malignancy? It's like we are asking about what you do in the real world practice. How do you often take help of Mayo classification? How do you often see the imaging and potential observe variability? Like, do you ask for a re-reporting? Do you ask some senior person to review or something like that?
Yes, Mayo imaging classification is very useful and a validated tool in real world clinical practice. It helps in predicting the disease progression as well, and also for guiding treatment decisions. As Sir rightly pointed out, if it is 1C, D or E, then of course, we have to think about starting disease modifying drugs like Tolvaptan. But there are some limitations as well, which we as clinicians need to be aware of. It is applicable only to PKD1 and PKD2. It was built only for PKD1 and PKD2 mutations. So we can't just apply it blindly for all ADPKD cases. It is not reliable in atypical cases like someone with asymmetric cysts or segmental cysts. Again, we can't apply that. And it requires accurate and reproducible imaging. Specifically, MRI is very ideal for that. CT is acceptable, but ultrasound is less reliable for
Agreed.
Mayo imaging classification. And of course, there is observer variability in total kidney volume measurement, especially if the measurement is done manually instead of using all these automated tools. So the best way would be to use something which is automated or semi-automated so that there is no variability in reporting. And again, it is dependent on age and height. Sometimes it might be difficult to interpret in borderline age groups or borderline volume groups. And minor genetic mutations, DNA JB11 or glucosidase alpha 2 subunit mutations, it may not be useful to use in such scenarios. So the best practice would be to use, if we have got an MRI report or maybe low dose CT report for accurate total kidney volume measurement, along with employing automated or semi-automated software whenever possible. And if you think that the clinical course is deviating, like for example, the patient is having stable GFR, but we are seeing high MIC class, then again we have to reassess and see if the classification is correct or not. Best would be to just combine eGFR slope and the genetic data for the holistic risk assessment. Of course, it is a very clinically impactful tool in guiding prognosis and also treatment, but it is not perfect, especially in atypical cases. It still remains the gold standard for risk stratification in typical ADPKD cases, PKD1 and PKD2 mutation, and it is important in guiding decision-making therapy, like to add Tolvaptan. We have been pressurizing our radiology department to use some automated or semi-automated tools to, calculators to, for whenever they are reporting the MRI with the total kidney, to provide the total kidney volume and the Mayo classification side by side. So it is an ongoing process in our setup. But yes, in some private labs, if they're giving it to us, then it is definitely a valuable tool, and we are definitely considering to use it for prognosticating and also for guiding treatment decisions as well. So that is one part of it. And the second question was about increasing the risk of malignancy. like renal cell carcinoma. ADPKD is associated with a slightly increased risk of malignancy, mostly renal cell carcinoma, but this risk is not dramatically high than the other CKD population or the dialysis population, and there's no strong epidemiological evidence also that links ADPKD to a markedly higher incidence of RCC than other causes of end-stage kidney disease. As clinicians, what we have to be aware of, and also what KDIGO 2025 guidelines says, that is RCC can present in an atypical manner in patients with ADPKD. Like the patients may have bilateral cyst, bilateral presentation or multifocal presentation. They might be younger in age. And the histologic types may also be not the usual ones. They may be the little different types of histological subtypes. And whenever ADPKD patients present to us with atypical cysts, like complex cysts on imaging, or there is a rapid increase in size of the cyst, or if there is persistent hemorrhage, patient coming to us with hematuria, but there is no infection or stone, some solid mass components in the cysts, if you are seeing something like that, then we have to be suspicious of renal cell carcinoma in patients with ADPKD. Coming to other malignancies in ADPKD, there is no definite proven evidence that ADPKD is associated with other malignancies, but there are some studies and case reports that suggest hepatic cyst adenocarcinoma, which is again very rare, pancreatic cystic neoplasms. Some studies are there. Colonic neoplasia, again, it might be confounded by family history and screening bias. So these are some case reports here and there, but otherwise there is no definitive or proven studies. Of course, post-transplant malignancies in ADPKD like skin cancer or colon cancer may be more common. This might be because of longer life expectancy and the use of immunosuppressive medications. I'm not sure if it is, if we can attribute it directly to ADPKD.
Right. Thank you so much. Thank you so much. That was a wonderful answer. Next, please. Yeah, actually, sir, this is a red flag scenario. What I want to highlight here: a 30-year-old male with 2 cysts in each kidney, intending to donate to his mother, who is an ESRD. So, would this exclude him as a donor? So, whether this is a red flag in your practice. And next will be the clinical scenario. Would you advise a pre-transplant nephrectomy for ADPKD patients as a default measure, or you can selectively advise this therapy? So these two red flags I want to raise to Dr. Sree, Bhushan, Raju, sir.
Yeah. Actually, a 30-year-old with a 2 cysts probably appears to be okay here. But actually, what I tell you is that most of the manifestations of PKD, they don't listen to your Mayo classifications and any kind of a criteria for the number of cysts and all other things over a period of time. That's what we should understand when we follow up the patients for several years and the decades. So that we have been seeing that actually. But a family history of ADPKD, which has been already there with leading to renal failure, a 30-year-old male, and is not an ideal donor, but still, if at all theoretical purpose, if you want to take him, I usually, if at all, if possible, I try to exclude him. And this is not the first time we excluded. We have excluded a number of times before that we told them that this kind of scenario will come very frequently in clinical practice, and we should tell them very strongly no. And if at all they just want, and we can actually call them and we can do a genetic analysis to see that what else can be there actually. If at all both the genes are similar, other mutations are similar between the mother and the son,
yes.
It's probably better not to. But if they are totally different and which are compatible with other genetic scenarios where the clinical progression is not a rapid one and is very slow one and all. But remember that he's just a 30-year-old. 30-year-old has gotten, as per the national statistics in our country, he has got another life of 45 to 50 years, which is almost more than double or more than double of what he has been actually led already in the life. So better to include him as a donor first of all, and better not to give him an option, especially in a scenario where we have so many disease donor transplantations, ABO incompatible, and so many, and wonderful dialysis program is there in the country, and and better not to punish the child for the mistake of his ancestors.
Right, sir.
Not to. That's the one which I feel, but still you can do genetic analysis only for the sake of doing it and explaining to them and convincing them and counseling them. That's okay.
Right,
The clinical scenario with pre-transplant nephrectomy, yes, I had a good number of patients for whom I advised nephrectomy pre-transplant, and most of them are secondary to kidney stone disease and
Yes.
recurrent infections and very large kidneys. Only to, and that too, it's very difficult for them to clinically go and roam around. Those cases, actually, I advise only unilateral nephrectomy. Many a times we advise unilateral, followed by a nephrectomy at the time of transplant surgery, especially the disease owner transplant. We don't advise both bilateral nephrectomies in a patient. I had only one patient who had a bilateral nephrectomy, and he's been doing very well, but it's very difficult to maintain the patients after bilateral nephrectomy and dialysis. They'll come back to you in the weekends, especially in a pulmonary edema and difficult situations.
Yes.
They have to go for dialysis in emergency situation.
Yes.
And
Yes.
uncontrolled blood pressure also is another major problem. They'll become absolutely anuric, and they'll not do very well if they don't get dialysis very frequently and more frequently than other people. So there's a reason ADPKD nephrectomy can be unilateral, and that should be having an indication, true indication in the form of a space constraint that can be just few days or a few weeks before to transplantation, either
Yes.
elective or at the time of surgery itself in cadaver transplantation, you can go ahead with a nephrectomy, or otherwise a major bleeding manifestation and
Yes.
so especially the stone disease with the multiple stones get stuck inside the kidney. There's a major indication because they'll get infections again and again. They lose the weight and they'll get into several complications, including malnutrition. So those kind of patients can be advised about the nephrectomy before transplant.
So point well taken, sir. Someone who is a nephric is a difficult person to manage on dialysis. That is what we understand. Next, please. So this is the time where we conclude, and it was a wonderful, wonderful discussion on a very niche topic of ADPKD. Thank you so much, Dr. Bhupesh. Thank you so much, Dr. Mythri. Thank you so much, Dr. Bhushan Raju, sir. And I know it has well past our allotted time, but thank you so much for contributing, and we'll keep catching up. Thank you so much, sir. Thank you so much.
Thank you.
Good night.
Thanks
Good
for
night from my
having
side.
us. Thank you so
Good
much.
night. Good night. Thank you.
Good
Thank you.
night. Thank you, sir. Thank you so much. Nice to meet you.
Thank you. Thank you. Thank you.